Hi, this is Dr. Connell. In this lecture, we're reviewing otitis externa. This is a classic picture of otitis externa where you can see the canal is inflamed. There's debris, and you may or may not be able to see the tympanic membrane because of the debris in the canal. The ear canal is the only part that's affected, or onto the external auricle. It does not go behind the eardrum. So you can see there's inflammation, pain, and drainage or debris in the ear canal. It can extend to the pinna, but that's a much more serious infection where you're getting a cellulitis externally, and it can even extend to the mastoid. But typically, it's just in the canal. It is not in the middle ear. If you're beyond the middle ear, then you have a different infection. Epidemiology is all age groups, males equal to female, and you typically see it more in the summer months where there's warm, wet climates where it could happen all year round, depending on where you live. So if you live in the jungle, you're more likely to see this all the time. However, for temperate climates, it'll be more in summer, less in winter. So the acute is the most common type of otitis externa. It'll occur in 1 in 125 people, which is a lot if you consider how many people there are in the world. Bacterial is the most common, and the two most likely organisms are Pseudomonas and staph. And that is what's going to guide your treatment. So you have to be sure that you're covering for Pseudomonas and staph when you're prescribing your topical antibiotics. There is a chronic type that affects 3 to 5% of the population. It's still, Pseudomonas is the most likely organism, but fungal infections can occur in chronic otitis externa, more so than in acute. Fungal is more common when it's long-term. There is a necrotizing or malignant otitis externa that can be fatal and can erode into the tissue. I've personally not seen that in my career. It happens more in older adults than in children. This is where you usually see it as risk factors from water. Swimming is big. Overuse of Q-tips. Cerumen is protective, and earwax is acidic, which is the normal flora that you want for your ears. So if you're really going in there and reaming out all your earwax, then you're less likely to maintain the normal acid-base balance and more likely to get an otitis externa. Headphones or earbuds or earplugs can increase the likelihood of otitis externa too, because you're keeping warm moisture in the ear. Things you have to think about is ear pain, which is called otalgia, that's idiopathic. Otitis media, either acute otitis or otitis media with diffusion. You can have dental pain that radiates up into the ears, and cerumen impaction sometimes can cause pain, and people, because the wax can lie against the eardrum and cause pain, but you wouldn't have the drainage coming out, and you wouldn't have inflammation of the ear canal, obviously. A cholesteatoma can get into the canal and erode tissue. They're more typically, cholesteatomas are more typical on the eardrum itself. Suppurative otitis media is a mimicker of otitis externa. Any drainage coming through tympanostomy tubes is also a mimicker. If the drainage is coming from behind the drum, it's not an otitis externa, and sometimes this is hard to differentiate. But the way that you can tell is if you push on the tragus. I'm going to turn my camera on a sec. If you push on the tragus and bend the tragus over the ear canal or manipulate the pinna, if it's drainage coming from the ear canal, that will not hurt. If it's an otitis externa and you push, it exquisitely tender, and people will jump when you do that if it's otitis externa. So drainage coming from the middle ear, coming through the middle ear into the ear canal, will not make the canal be inflamed, and it will not make the canal be tender. So wiggling the ear canal or palpating onto the tragus are the things that differentiate that from a suppurative otitis media or drainage through tubes. So in subjective data, we always do the same. You do your old carts. What have you tried so far? Most people have tried something before they get there. Sometimes these come on very quickly. You want to see if there is a family history. You always look at smoking history for, as always, and infections, and then swimming or moisture in the ears or Q-tips or earbuds. So you assess for all those things. Symptoms are, the two biggies are pain, especially with touch, and itching. Sometimes just running your comb over your hair, like a hairbrush running over it, or lying your head on the pillow on that side will really hurt. And so you can ask if lying your head on the pillow on that side hurts, and does it hurt on the other side. Discharge is usual but not necessary to diagnose it. Plugging of the canal will cause a loss of hearing if there's a lot of debris or if the canals are very swollen. Key finding is that people are afebrile. This is not a systemic infection. It's a localized infection. So on the objective, you do a complete ENT and nodes. With an otitis externa, the preauricular node will be tender and present. Usually you don't feel preauricular nodes, but with this you will. You will have a tender tragus. You always check the mastoid and the pinna for erythema, edema, or pain on palpation. Once you're doing your otoscopic exam, the canal will be inflamed and edematous, and there's usually debris. And sometimes it's so edematous, like I said, that you can't see the drum. You don't need to do any diagnostics. This is a diagnosis by looking in there, the symptoms with the looking at the canal, and that's how you do it. Occasionally you will, if it goes on for a long time and becomes chronic, then you will need to do cultures. But that's not very common. All right, so the plan, if you can get the debris out of there, because the debris is interfering with the treatment. You're trying to put in drops, and if there's a lot of drops, apparently if there's a lot of debris, the drops can't get to where they need to go. You can sometimes suction the debris out or lavage it with half-strength hydrogen peroxide or warm water. Sometimes the canal is too tender to do either of those, and these are quite tender, so sometimes that's not possible. The pain may be severe, and sometimes just NSAIDs are fine, but occasionally you do need very short-term opioids for 48 hours, rarely 72, just till you get the infection under control. So for the infection and the inflammation, remember you're treating Pseudomonas and staph. So the fluoroquinolone drops, the otic drops, remember otic is ears, fluoroquinolone drops with or without steroids. Ciprodex, otic drops contain dexamethasone, and sometimes if there's a lot of inflammation, you will need to have the dexamethasone as well as the antibiotic. If it's just straight infection and there's not much swelling of the canals, then you can get by with just a plain floxin otic or a cordysporin otic. But cordysporins, remember, have an aminoglycoside in them, and aminoglycosides are toxic to the middle ear. So you would only use cordysporin otic if you're pretty sure that the tympanic membrane's intact. You would not use that if they had tubes or if there was a perforation of the drum. It's very rare to use systemic antibiotics. unless there's an external ear cellulitis radiating out onto the mastoid, or if the person is significantly immunocompromised. So topical agents are the first-line treatment. This is something you may have to do. These canals get so inflamed that sometimes you can't get one single drop down the ear canal. If that happens, you get these tiny little sterile cotton wicks, and you buy them in a little pack, and you very, very carefully, I'm going to turn my camera on again, you very, very carefully get your tweezers out, and you just slowly enter it into the canal. So it's just very, very slowly. Once it's in the canal and you want to get it as far down as you can, then you instill the drops, and the drops will suck down through the wick, so they will get to where they need to go. And that is something you will do almost certainly in your clinical practice. So if you have a fungal infection, it's more likely to happen in chronic otitis externa. You still want to remember fungal infections are opportunists usually. And so you still want to restore that normal acid-base balance. So 5% acetic acid is vinegar, white vinegar. You don't want to put apple cider vinegar or something in your ear. But acetic acid with equal parts of rubbing alcohol, just 1-to-1 solution, can restore the normal acid-base balance. The alcohol dries out any moisture, which fungal likes moisture. So the acetic acid restores the acid base, the alcohol dries out the ear canal, and sometimes that's all it takes. There are also antifungal solutions that you would need. You would not start with this, but if you had a chronic OE, you would start looking for fungal infections. The malignant otitis externa is about the only time you would need to refer. Like I said, it's higher in older adults. The thing with a malignant otitis is that it's usually with other parts of the body are affected. Like you might have facial paralysis, you may have ulcerations, and it's more systemic, so you're likely to have a fever, and the pain is increased. So that's a picture of necrotizing malignant otitis externa. Q-tips are to be avoided for prevention. Remember, the cerumen maintains a normal acid-base balance. While the swimmer's ear is healing, you really want to not be in the pool. Earplugs don't really work because they fall out most of the time. And also earplugs can keep all that warm, moist air in the canal, which can increase the infection. So it's really kind of a bummer for kids sometimes that they can't be in the pool or at the lake for a week or so. But you really want to just get that dried out. So if you're, say, a swimming team person and you have to be in the water for a longer period of time, blow dry the ear canals after swimming and put in equal parts rubbing alcohol and vinegar on a daily basis. And that's it. Thank you.